Welcome back, everybody. Next presentation comes to us from Brainstorm-Cell Therapeutics. We'll hear from Dr. Bob Dagher, who is Executive Vice President and Chief Development Officer, who will be telling us about biomarker exploration of neurons' multimodal mechanism of action. Welcome, Bob.
Thank you, Fernando. Let me share my screen. Can you please confirm that you can see it?
Yes.
Great, thank you. And hi, everyone. So my name is Bob Dagher. I'm the Chief Development Officer here at Brainstorm-Cell Therapeutics. It is a great pleasure, and thank you to the organizers to allowing us to share our data and continue the learning of what cell therapy has been able to do and continues to be doing, and what are the learnings from the biomarkers data. So as the title of this presentation spells, we are looking at multiple mechanisms of action that are interrelated, complex, and tackle several biological pathways from, of course, the neurodegeneration cell death to neuroprotection and certainly the inflammatory process. So I'm going to walk you a little bit through the current thinking and the future direction of what we at Brainstorm-Cell Therapeutics are trying to accomplish and learn and moving forward. So quickly here, we all know the disease is multifaceted, multiple mechanisms underlie ALS. We continue to be learning about the interplay between, of course, the immune system in the brain, the inflammatory processes, as well as the cell death and protective mechanisms behind that. Certainly, there is a potential from stem cells to offer synergism across multiple pathways, and that's what we're trying to achieve, and that's what has been basically by design brought forward to see how much we can affect at which levels and in what sequence. Just as a reminder, the choice of mesenchymal stem cells is very important in their innate ability to modulate the immune system, and that's very relevant for neuron. Just quickly as a fundamental physiological background, stem cells have multiple physiological actions, from scavenging excitotoxins, reactive oxygen species, angiogenesis promotion, glial support, reducing scarring and inflammatory process locally, repairing the barrier, promoting neurite outgrowth, and a number of mechanisms can be exploited via diffusible factors, gap junctions, exosomes, different ways to approach the complex problem. So what are the lessons to date? And we continue to be learning by the day, and just today, this morning, from the lectures presented, there's a lot to be uncovering with this complex disease. So first and most important in neurodegeneration, we know that you want to treat as early as possible. You want to put a break in the disease cycle. It's much more tractable to protect circuits that are established rather than to try to replace them and reconstitute the anatomy. Transplanted cells have to mesh and live in a homeostatic fashion in the target organ here. And we are concerned with the spinal cord and the brain. And obviously, there are a number of imperatives to be successful at the target organ level and at the cell level as well. So we have to match cells that can belong in the milieu where we send them. And certainly neural stem cells, mesenchymal stem cells do that. They have their biological function in sync with the target. And we want to promote reciprocal talk between the same cell types and different types of cells that are present in the same organ. And finally, we understand now, we have learned that you have to reach the target, obviously, to have maximal effect. You have to spend certain amount of time there and at a certain requisite dose to expect therapeutic benefit and response. So what does neuron offer? What are these mesenchymal cells that secrete neurotropic factors able to add to the armamentarium? This novel stem cell therapy is basically aims to access the cerebrospinal fluid via intrathecal administration and exercise its homing mechanism to go across, over from the lumbar area up through the spinal cord and into the cortex, and modulate the inflammatory processes and reduce neuronal death and promote survival, and by that improving function. That's the aim, that's the goal, that's the hope. The choice of autologous cells is very important, as we know, using the individual's own cells is critical to avoiding some of those unwanted immune responses. So with that, I'll remind us all of the design of this phase 3 trial of Neuron and ALS that was completed and read out, etc. Pointing at the bottom of the slide on of the biomarker sampling, the CSF sample through lumbar punctures was done at 7 distinct times. This is a very robust program for biomarker program that was conducted. So this study, as you know, had a 20-week pre-treatment period, about 5 months, where we basically measured disease progression before baselining all 95 individuals on Neuron and 94 in placebo at baseline. And then we had 3 dosing at, as a reminder, at week 0, 8 weeks later at week 8, and 8 weeks after that at week 16. And you can see here quickly that we measured CSF every 4 weeks, roughly, except early on at week 2. We had an additional sampling as well for trying to track the early changes as well. So all the way from week 0 to week 20. So different pathways, biological pathways were studied. The relevance to ALS obviously is neurodegeneration, with a number of those biomarkers highlighted here. The ones bolded are the ones that we conducted analysis on and reported on, and I will be showing you that data next. Neuroinflammation, both on the anti-inflammatory facet with TGF-beta1, as well as on the pro-inflammatory effects seen on MCP1 will be presented as well. Neuroprotection, galectin-1, VEGF, and other biomarkers were measured as well, BDNF, clustering, etc. And other biological pathways, relevant biomarkers were in that pool. So starting with the important neurodegeneration biomarker, neurofilament light, that everybody has been educated on and aware of in recent years, with the latest approval of a medicine for ALS. We see here a early change in neuron, an increase at week 2, that earlier time point I mentioned before. And then we see a steady decline through the duration of the trial all the way to week 20, where we reach a significant difference from placebo at 11% reduction. Placebo maintained that stable level from baseline all along. So that was important to see that it's heading in the direction that we are expecting to see. And then we looked at other neurodegeneration biomarkers as well to support and complement this finding. Here we look at phosphorylated neurofilament heavy on the left, very similar pattern to neurofilament light. You see a slight increase early on, followed by steady decline all the way through the end of the trial. Basically, very, very similar pattern to neurofilament light. Interesting on the right side as well, the death receptor 6, you see a very early decline. At week 2, you see a sharp decline down and maintain that beneficial level that we want to see with the decline all the way to week 20, however, at much lesser or a lesser extent. So all in all, in neurodegeneration, we can see from these readouts that we have observed the trends that we want to see following neuron treatment, that on neurodegenerative biomarkers, we see an effect that is in line with what one would anticipate. Obviously, the precision and the magnitude and the timing, these factors are still factors, subject of study. The biomarker data coming out lately continues to be educating us on what must happen, how early, and for what extent, and for how long. And these answers hopefully will be answered with future experiments. On the inflammatory biomarker side, on the left, we see anti-inflammatory biomarker TGF-beta1. Also, as expected, the beneficial increase of TGF-beta happened early on at week 2 and maintained a span all the way throughout the duration of the trial, with a 9% increase at week 20, the last measured time point. On the pro-inflammatory side, we see MCP1 levels going down as well significantly early on at week 2, with 31% reduction from baseline with that, and we see that maintained throughout the duration of the trial as well, yielding 23% reduction at week 20. By the way, you see the curves for placebo in gray that maintains stability from baseline with no change, as one would expect. On the neuroprotection side, biomarkers measured here, galectin-1 on the left and VEGF on the right, you see the same trend expected as well. An increase, a sharp increase early at week 2 following that first dose at week 0 at baseline, and then followed for a trend above placebo throughout the duration of the trial. Again, the magnitude of increase is sharpest early, and then an increase at week 20 with galectin-1 of 13%, and same trend we observe on VEGF as well. So to put all this together, we look to Dr. L.J. Wei from Harvard, who have developed a methodology for measuring Z-scores that can help us ask the question whether all of these trends or findings would they be happening as by chance, as a spurious finding, or what is the probability that this could be actually a true treatment effect generated by neuron. So when we looked at NFL, MCP1, TGF-beta1, and galectin-1, here you see, and we measure the Z-score for these 4 biomarkers together, the probability that this finding could be spurious by chance is very, very low, at a p less than 0.0001. So this gives us a level of confidence that we see a biological effect here that is real, that neuron exercise on these important biological pathways in the direction that we look for and hope for, that starts early and maintained throughout the duration of the trial at the different time points that we're able to measure. And just getting 7 lumbar punctures in people with ALS is very, very challenging, and we are obviously very thankful for everyone for being able to generate this type of data and this wealth of information that is coming out of this. So in summary, we basically know for sure now that in the overall population, the primary endpoint that was selected did not reach statistical significance. A lot of debates and basically analyses followed that finding. A number of pre-specified analyses were conducted, as well as post hoc analysis to look at specific questions, subpopulations and endpoints, etc. The results from subgroup analysis with less advanced disease were very important to us. They showed significant and consistent treatment with neuron across multiple endpoints and over time. So obviously, we at Brainstorm-Cell Therapeutics are very energized by that, and we're looking now to conduct an experiment asking the right questions in this population with the endpoints of interest and figuring out the role of neuron in this disease. We have supportive results, as you saw here briefly from this quick presentation on biomarkers, that the biomarkers data is very helpful. It shows us an effect across the overall population and also in the subgroup analysis as well. And finally, very importantly, we have now conducted a number of human trials. The safety profile, we understand, we know what to expect. The repeat intrathecal administration profile is now well understood as well. Every 8 weeks dosing has been done several times, including in the expanded access program as well. Repeatedly, we are looking for a positive benefit risk profile in mild to moderate disease, and we are looking to conduct the confirmatory phase 3b study moving forward to basically ask the right questions, hopefully get the answers that will be satisfactory for a regulatory filing application. And this is my last slide, and I will stop here. I'm happy to take questions now or later.
Thank you so much for a great presentation. It's an incredibly powerful sample set and data set, really valuable. A few questions from the chat. One was a question, I think you made the comment, but did you sample for CSF at 28 weeks as well?
No. So the sampling stopped at week 20, and already 7 samples, the design could not ask for more sampling at that. That study design was done many years ago as well. But it's a good question. We are considering that, the importance of sampling at the very last endpoint, very last follow-up in the double-blind placebo-controlled phase of the trial, and this will be a matter of discussion at this stage.
And related to sampling, were the averages or mean values, given that it was repeated measures, were they affected very much by either study attrition from people passing away or by people coming out of the trial? Or were you able to have the same N for each time point, your N of 95 and 94 captured at baseline and also captured at 20 weeks?
No, the answer is no. So let me give 2 important facts here to be cognizant of. Fact number 1 is that we had a number of missing samples. Remember, this trial was executed during a pandemic, a global pandemic, and there has been, during that pandemic, there were a lot of difficulties for people to go to the hospital and get their lumbar punctures done outside of their 3 treatment visits at dose 1, dose 2, and dose 3. So at week 20, for example, we observed a number of missing samples. Fact number 2 is that we expected that there's not always 100% compliance with all of these experiments. So we had pre-planned and also conducted a number of sensitivity analyses looking to account for missing data and biomarkers, etc. The summary end result of all of this did not show us that the data, when you do sensitivity and when you basically look at smaller sample size, did not contradict the overall conclusions that I just shared with you here. So all in all, overall, we see the same trend that is seen for the entire population with the number of samples that we were able to measure.
Thank you. Thanks for clarifying. And I think we have time for at least one more. So there's a question on your perspective, like from your mindset, which is more important with reference to axonopathy, NFL or phospho NFL or phospho NFH, neurofilament heavy? Do you think one is more relevant than the other, or not?
Yeah, as I said earlier, we're still learning a lot about this. I will take it with two angles. From the regulatory angle, as was mentioned in the previous presentation by another colleague, we have to consider the regulatory world that we live in and the advancement. And since the neurofilament light has already set that precedent for a surrogate measure of function, and we could no longer ignore it. So I would tackle that first question, the regulatory side, that we have to analyze neurofilament light and see the importance of it. And the second, the flip side to that is phosphorylated neurofilament heavy has a lot of wealth of data as well in ALS and other diseases, other neurodegenerative diseases, etc., and certainly carries value from a scientific perspective, similar to neurofilament light. So I'm not sure that there is one jury out there that could sort of definitively call one over the other, that one is superior scientifically or not. But as I said earlier, from the regulatory perspective, we cannot ignore neurofilament light.
Well, thank you very much. For more opportunities to ask questions, I hope people will be able to catch you in the panel later. But thank you very much, Bob, for your presentation.
Sure, thank you very much.